So then now we get to the neurotissues of the forearm, wrist, and hand. So what kind of nerves do we have in that area?
Ulnar nerve, median nerve.
Radial. Right. So where's the sensory distribution for those nerves?
Median nerve.
Median's right here.
Ulnar goes.
Ulnar's both sides on the last two fingers. And then where's radial? Basically what's left. Kind of back here. Sometimes you'll see different charts where it'll show the median doing the back of the tips of the distal part of the fingers. And that the radial is just more here at the wrist. So what areas are they going to be vulnerable to having problems mostly in the wrist and the hand? Anybody? What happens to the median nerve right here? You might have heard of that before. Right, carpal tunnel syndrome. Is there another tunnel over here? Yeah, the French tunnel, right? Okay. And then what about the radial nerve? There's not really any tunnels that it goes through, but sometimes you can get irritated here at the wrist, like wearing tight wristbands or something like that. Right?
What about things like ganglion cysts?
Those are in the tendon. Okay? It's like a swelling or something that builds up into the tendon. Because you'll see that, if you're going to try to differentiate, how would you try to tell? Because sometimes it could be bone, right? There could be something bony sticking out here versus a tendon. How would you tell the difference? What would you do?
Have the bone move, the tendon move.
Right. Tendons are going to move, bone's not going to move. So if you do this, and you feel it move with the tendon, then it's a ganglion. If it's not, then it's more likely to be bone. All right, so then we'll go through the different hand and wrist conditions, and then what you want to know is what's going to be significant about each one to make it different from all the others. Now, some of the mechanism of injuries are going to be similar, but each one will have its own distinguishing characteristics, like neurologic things. If somebody says they have numbness and tingling right here, what are you going to suspect? Median nerve, and so you could be from the carpal tunnel, could be up into here, could be up in here, but median nerve, peripheral nerve distribution, remember, is different than nerve root. So there's a little bit different distribution. Right, so then what kind of things do you think we'd be doing for special tests to evaluate the inert tissues? It's going to be similar to what we've done in other areas. Right, what are you going to do for bone? What's that? Yeah, for joints, right? But you can, you can tap on it, or you can, tap from a distal area here, compress on it, things like that. And then, yeah, passive range of motion. And then ligaments are part of inert tissue. So what kind? Remember what did we do for inert tissue for the elbow? For ligaments specifically.
Tragus and varus.
Right. So could you do that here on your fingers?
Mm-hmm.
Sure. There's going to be a little more motion here at the MCP versus the PIP and the DIPs. But it's the same kind of thing. And then contractile tissue, we mentioned that before, you're going to do either active range of motion or stretching at the end of range of motion or active resisted range of motion. And then neuro tissues, there's 3 different things that we do to evaluate nerve tissue. And what's that? What's that? Yeah, basically you're doing something to narrow the opening that it goes through. Okay, so that could be compression like this, or it could be squeezing on something like that. So you narrow the opening that it goes through. What else?
Stretch it.
Stretch it and tap on it. Okay, so we'll do something to tap on the nerves. We'll do something to stretch them. And I think there's a few that we'll do to narrow the opening. But mostly it's going to be obviously at the wrist here, because that's where, in the hand and wrist, that's where the nerves get affected the most often. All right, so we talked a little bit about the triangular fibrocartilage complex. And what's the anatomical snuff box? Right here. Okay, what's that?
Longest and
There's one more too, but What's the bone that's in there? The scaphoid or the navicular, okay? That's important bone because whenever somebody has a trauma to the wrist, you're gonna suspect that they have a navicular fracture unless you prove otherwise, because that's kind of like the red flags. And somebody was asking before about, what are red flag things. The main thing is that you need to identify, if somebody comes in, you need to know, okay, this is a problem that needs to be addressed by orthopedist or whoever else, neurologist, whatever. So you need to know that, this is something that needs more attention, that it's not something that I'm going to deal with right now. So if you suspect that somebody has a navicular fracture, because there can be complications where the blood supply can be disrupted to that bone and they're going to have avascular necrosis. I had a patient that broke his snowboarding. First he comes in with a cast up to here, and then I don't see him for a month or two or something, and then he comes back and says, well, yeah, I had to have surgery because it wasn't going to heal, or there was some vascular compromise or something like that. So navicular is something that's important to make sure that it gets taken care of properly.
What was the bone you said?
The navicular or the scapular. Because, well, we'll get into it later, but basically it has two different blood supplies to it. And if it breaks in the middle, one end can lose its blood supply. All right, so opposition, that's a new part of range of motion that we haven't talked about before. What opposition basically is bringing the thumb towards the fingertips. It's like you're bringing the hand together where all the tips are meeting. So that's opposition. And we talked about retinaculum. And what's stenosing tenosynovitis? What does that sound like? What's that? Yeah, because, well, it's like you're thinking of stenosis of the artery, but it's basically the tendon goes through a sheath, and then it's constricting to that area where the sheath where it goes through. So like the sheath can get swelled up around it, so it's constricting at the opening where the tendon goes through. And it's usually by soft tissue. Okay, so that's basically a summary of what we're going to talk about. So now we'll get into all the details of it.
Could you please go over what retinaculum is?
It's a ligamentous tissue that usually goes perpendicular to tendons and helps to hold them in place. It's usually around areas like the wrist, the ankle, anywhere where where the tendon might curve and you need something to hold it in place. Like let's say, if you're coming back like that, if there wasn't anything there to hold it, your tendon would just go in a straight line like that. So this kind of just straps it in and holds it in place.